Okay, so I would like to welcome everybody to this session in one of our plenary sessions, and the topic is truth-telling and therapeutic lying. Professor CAIT Irving is going to be talking about dementia, when is the truth a lie, and Professor Ian James is going to be talking about approaches to behaviour that challenge therapeutic lies as person-centred interventions. So I'd like to say just a few words and then I will hand over to Kate, who is our first speaker. So welcome to everybody for joining this session with us today. My name is Sinead Grennan. I'm CEO of Engaging Dementia. I'm stepping aside this week, and Kim Tully, who is co-hosting the conference, is going to be taking over the role of interim CEO while I do a full-time master's in psychology. So you'll see Kim during the 2 days as well. We are recording this session and we have a YouTube channel, and we'll be putting up all the conference sessions in the coming weeks. We have a really packed program, so everybody who has tuned in now, you'll have got a link for, there are 2 threads every day. There's kind of a plenary room and a parallel session room. So all you need to do is click on the link for whichever room to go into that session. And you will have also got our program, and it's also up on our website. Finally, we're pretty active on Twitter, so anyone who is into Twitter, do feel free to join the conversation there. We're at Engaging DemIRL, and we have a hashtag DementiaConf20. So over the next few days, do feel free to kind of engage in the discussion there. So this is the 12th, this session is part of the 12th International Dementia Conference. There are 2 conference days, and then on Wednesday, there's kind of a wrap up with a policy and practice forum that's being co-hosted by the Dementia Research Network of Ireland and the HSE National Dementia Office. Okay, so, and everybody who is joining in, you can submit a question or a comment through Q&A or chat. All right, so I will hand over to Kate.
Thanks everybody for coming along to listen, and I hope we can provide you with an engaging session. I'm just going to share my screen now. I want to sort of start off by saying that this talk is very much, whilst it's informed by some academic readings, it's very much a personal journey. It's a talk I did originally a while ago with Engaging Dementia, and it's academically informed, but it's quite a personal reflection on my own caring journey with mum. So truth-telling is a virtue. We learn it from the start of our lives. To tell the truth is taught as a black and white thing, the lie or the truth. But in reality, there are some shades, and some shades of virtue in the grey parts. So there's definitely not a black and white lie. And this isn't just in dementia. This is quite probably, I would like to argue, for all of us in all of our lives. So if we use consequences of, just move my pictures out of the way. If we use consequences as a basis of moral worth, some would say that lying is completely right because it makes people much happier. And this is a kind of consequentialist view on lying. And it's one that gives a lot of people a lot of comfort, I suppose, around the idea of lying. I mean, I'll come on to some critiques of that way of thinking, but to start off with, I'd like to make reference to some ethical theory from Immanuel Kant. And what he would have said was, nobody should tell a lie ever. Lying is always wrong, because lying cannot pass one of his first maxims, which is the universality test, and the second test, which is the humanity test. So what is that? Well, the universality test is, even if everybody lies, then all words that we use lose their function to express any truth. So the principle of lying can't be universalized. So in other words, if we asked if everybody was to behave in this way, would that be okay? And of course it wouldn't be okay, because if everybody always lied, there would be no function of words any longer. And the second big argument for not lying is that we can only really lie to somebody successfully if we use one person's ignorance as a means to somebody else's ends. And so Immanuel Kant would have said we should never ever use somebody's as a means to somebody else's ends. So what does that mean? I suppose to look at the consequentialist argument, an action is right or morally good if it's used in promoting happiness and preventing pain. And Bentham, who's in kind of juxtaposition with Immanuel Kant on this, ethically speaking, says that nature has placed mankind under the governance of two sovereign masters, pain and pleasure. It is for them alone to point out what we ought to do, as well as to determine what we shall do. On the one hand, the standard of right and wrong; on the other, the chain of causes and effects are fastened to their throne, the throne of pain and pleasure. They govern us in all that we do, in all that we say, in all that we think. Every effort we can make to throw off our subjugation will serve but to demonstrate and confirm it. So Immanuel Kant set a very strong kind of ethical principle that we should never lie because it can't pass the universality test and because it's not in keeping with human dignity. And Jeremy Bentham set this other thing that we should always do what causes the most amount of pleasure and the least amount of pain for the greatest number of people. So what's wrong with that? What's wrong with only considering the consequences? Well, first of all, I think, using somebody's as a means to somebody else's end, it is very problematic. So whilst it might be harder to think of, this sort of duty-based ethics where we have to override some kind of initial instinct to do something, the consequentialist view kind of does become problematic for us. And there's one really famous test that it's a thought experiment that the ethicists use to help people to think this through in a kind of demonstrable way. And it's the idea of this: you're the driver of a train and the train is hurtling down the tracks. It's completely out of control. The brakes have failed. You're driving it and you have a choice. You can continue to plow on down the tracks and kill 5 people that are standing on the tracks in front of you, or you can drive off to a side road, a side track, and kill just 1 person instead of 5. And at this point, most people say, oh, to kill the 1 instead of killing the 5, it would be, and that's a really consequentialist sort of point of view of, causing the least amount of pain to the least number of people. But then when we test that and we say, okay, but now you're not the driver of a train, you're standing on a bridge and there's a really, really large gentleman standing next to you. You can't throw yourself over because you're not large enough to derail the train, but you could throw this large man over and derail the train and save everybody but kill 1 person. And most people now find that actually I would find that quite difficult to do. They change. So they're not so pure consequentialist now when actually they have to do something like push someone over. So what's the difference? It's just 1 life in exchange for 5 lives, or however many people standing on the track. And that's a problem with the consequentialist argument, because when it comes to it, if you have to do something that follows up on the consequentialist argument, it is really very difficult, because there is something very instinctive within us that says you can't use 1 person's life as a means to somebody else's ends. And I suppose lying to somebody with dementia is kind of like using that person's ignorance or not knowledge of what's going on as a means to your own ends. And that's how it can feel. And I suppose the other thing that's fundamental to both these two ethicists is that they say that you should be a disinterested stranger in terms of making an ethical decision. And at no point ever when you're caring for somebody with dementia, either as a professional or as a family member, are you a disinterested stranger? So this is really difficult, because we could change the scenario and say that the 1 person standing on the tracks is your baby brother or sister. And then it's even more difficult. But according to the ideas of universality for both Jeremy Bentham and for Kant, you should be a disinterested stranger, so that life is just 1 life, the other life is 5 lives, and everybody should be treated universally as 1 person, regardless of your particular relationship with that person. And so all of these, and they're just thought experiments, they just kind of help us a little bit to think things through, but they all leave a very deeply problematic situation for us. So where are we on lying? Well, I would say it depends. I suppose in all of the care ethics that I would kind of teach to student nurses and kind of use in my daily life and dealings with people with dementia would say that absolutely we cannot be disinterested subjects in the lives of the people who we care for, but we need to foreground interdependency and vulnerability, pay attention to the needs of concrete particular individuals in their situations, not fictitious ideas of what we might do if we had to drive a train down tracks that brakes were out of control. I think one of the other really important things is to validate these traditionally feminine virtues of nurturance and empathy, and affirm the importance of being actively concerned with the welfare of others, and recognise the role of emotion in moral life. So, emotion. I think it's a personal feeling, but I have a very strong belief in the need for emotional presence in caring for people. And by this I mean, and certainly with regards to my own caring for my own mum, I mean being open to the emotion that mum is feeling, certainly, but also being open to the emotion that I'm feeling in any given moment. Because not acknowledging that and pushing that away can often leave me feeling quite dissatisfied and riled or grumpy, but being present and understanding that that's how I'm feeling means that I don't act out of that place of being riled, because acting out of that place may lead me to search for control in a care situation. And I think very often this is what happens when we care for people with dementia, particularly people who we know very well, because let's face it, it's very few people like your own family who can push your buttons. So when I recognize that I'm feeling a little out of control, my search is for something to help me feel in control. It is not to search for something that helps me to control my mother or any person with dementia I've ever cared for. And I think this is the problem with the term therapeutic lying, is that it seems to imply something. And I know Ian's going to go on to talk about that and what it means and what it doesn't mean later on. But the term seems to imply that it might be therapeutic to lie, and that can chime in with this idea of feeling a need for control, and then the lie can come from the wrong place, I suppose. And that's all really that is important, is that whenever you are caring for somebody with dementia, you stay emotionally present, and not just to the emotions and validating the emotions that the person feels, because that really is only half of the picture. What's really, really important is staying emotionally aware of your own feelings and how they are causing you to respond. Because when my mum says that I'm not her daughter, she never had a daughter, where she has a son, you know, but she never had a daughter, of course that hurts my feelings, and somehow denying that can only ever do something bad for our relationship. But also acting out of a place where she doesn't acknowledge me is also going to be very problematic. So in order to feel in control of myself, not of my mum, I know I can reduce the number of options of how I'm going to respond under pressure to just kind of 4 options. I can tell the truth. I can try and validate the emotion that she's feeling. I can do a little fiblet, or I can just tell an out and out lie. And how I cycle through a kind of like a holding pattern, like a like an aeroplane going round and round an airfield before I land on which one of these I'm going to do. So truth telling might go something like, oh, Mum, I know you miss Nanny and Grandpa, but they aren't with us anymore. They lived very long lives and we cared for them the best we could right until the end of their lives. And if they were alive now, they would hate you to be worrying about them. And validation might sound like, oh, this is in response to Mum asking where her parents are. Validation might sound like, oh, you're very worried about upsetting your parents. Are you worried they're going to be worried about you? They worry about you a lot, don't they? And then the fiblet is, Nanny and Grandad are not worrying about you. I know they're fine. Nanny and Grandpa are not alive anymore. You might have guessed, given the wrinkles on my face. I don't have grandparents. And then I can just tell a lie. Your mum and dad are very well. They're in the shop and I'm sure they're very, very busy. So Option A, just telling the truth, used to work really well in the beginning with dementia in the early days, but it can still work really well now. Even though most of the days she doesn't know who I am in terms of being her daughter. She knows I'm somebody she likes and I'm kind of nice, but she doesn't know exactly who I am. So, you know, even now she can say to me, oh, thank you for telling me that, because I was so worried about them. Then now I don't have to worry because they're not here anymore, and that's fine. So have we had a funeral? And then we can start talking about the funeral, and then that's usually nearly always a comfort to her in those moments. If I go in with option A, and she's totally impervious to everything I say, and so she says to me, I say, Nanny and Grandpa, we had a funeral and they're not alive anymore. She might say, yeah, okay, but can we ring them? And if she says that, I know that staying in option A, in option 1, is absolutely not an option any longer. So that option has now been closed off to me. And then option B might go something like, she might say, I'm in a terrible mess. I can't remember where I parked the car. And I might say, you've lost your car? My goodness, what can we do? What does it look like? Can you tell me anything about it? Have you ever misplaced a car before? How did that turn out? So I might try and kind of tread water, getting her to unpack some of her emotions around the car and what that means to her. And the more negative her responses to my questions helps me to know whether I'm okay at staying in the validation mode or whether I need to move along. And you know, there's different things that have helped me with this, and one is just paraphrasing whatever she says. So saying exactly what she says back to me, back to her, in a sort of almost parroting, as long as it's respectful way. So she might say, I'm in a terrible mess. I can't remember where I parked the car when I got here. You can't remember where you parked the car? Well, it wasn't my car. I borrowed it. You borrowed it. And it's hard to see how that kind of paraphrasing or just giving, not even paraphrasing, because sometimes when you're in the moment, to paraphrase is more than you have capability that you have when you're trying to mount a response quickly in response to somebody who's really upset or angry or frustrated or whatever the big emotion is that they're feeling. So that just saying back the words that they said to you is mightn't fix the problem, but it's very rarely ever going to escalate the problem in the way that contradicting the person with dementia can often do. So it's a really good way of treading water and exploring how the feelings are and what the feelings are, and making sure that you're right about what it is that's the feeling, because oftentimes a person with dementia might express things angry, but actually they're just feeling really sad. So it's a good way of exploring that. But if you're not getting anywhere with there, then I might suggest I'd go on to option 3, which is the fiblet, a sort of lie by omission. It's not a distraction, it's a lie by omission. So obviously I'm not going to tell her, you don't even have a driving license anymore, or, you know, you live here, Mum, why do you want to go somewhere? You know, I'm not going to tell her any of those things. I'll use an ambiguity of what's going on and where she is in order to work towards something that she can feel more comfortable with. There are times when she is really lucid, even now, and we're 8 years into the diagnosis. And she says things to me like, please don't ever lie to me. And she said to me once, this doesn't make it any easier, by the way, she said, you're like the one signpost sticking up out of the mist. And if you start lying to me, where will I be? So it is really, really difficult for me personally to move on to option 4. However, in those moments where nothing is going in and I say to her, but Nanny and Grandpa died 11 years ago, she might not hear that, but she might hear somebody's murdered them, or some other thing that she hears that is absolutely catastrophic to her. In that moment, she is not in a place where she can say, oh, thank you for telling me that, because I don't have to worry about them now. And at any time in any one day, she may be in any one of those places. And so I have to continually keep searching for, what does she need from me now? What does she need from me in terms of what degree of truth telling or kind of fiblet or lie? And even though I know this, I still, and I don't know, it's probably something to do with my upbringing, which she is also responsible for, at least half anyway, that I find it really, really difficult to lie to her. I find, you know, and that has been a learning for me in terms of caring for mum over the years, is that I have to go, it's like a 4-step dance, and I have to choose the step each moment that gives that to the best of my abilities respects mum, and help, and having this 4-step framework to dance in really helps me to feel in control of myself and my own emotions, so that I can lie the best way that I can, but most importantly for me, to the least extent that I have to. I cannot call lying therapeutic, you know, because it doesn't feel like a good thing to me. It doesn't feel like it's good for me to tell a lie, particularly when mum's really, really confused. And like she had said this thing to me about being the signpost in the mist. So it's a really hard thing for me to do, but I do recognize that sometimes I have to do it. Do I then call it therapeutic? I don't think so. I call it the best of a set of really, really shitty things that sometimes I have to do. And that's as far as I can go in terms of kind of going there with a therapeutic lie. Sometimes we have to do it. I don't celebrate it, and I revert back as soon as I possibly can to option 1 or option 2, and it's a continual dance that I'm doing all day, you know, at the weekends, all day, every day, and continually seeing, what does she need from me now?
Great. Thank you so much, Kate. Kate is referring to our system instead of nonverbals for, you know, in a usual face-to-face conference, which we would have had in June. We were going to have a nonverbal system, which actually we haven't had to use because everybody has kind of, you know, kept to the time generally. So, which is really helpful because it means we cover the program and then have time for some discussion. So thank you so much, Kate. I will now introduce Professor Ian James, who is consulting clinical psychologist at the Cumbria, Northumberland, Tyne and Wear NHS Trust. And there's Ian, who is speaking about Therapeutic Lie's communication model for effective dementia care.
Well, thanks very much. Thanks, Sinead. Thank Kate. Yeah, I guess my perspective is many very similar things. I guess I'm coming from a perspective where I've been working in the area for about, 22 years. I've always been quite frightened about saying the wrong thing. And so very quickly, when I started working in the area, I read an awful lot about communication skills and how to talk to people with dementia. And since then, over the years, I've not said I've got any better, but I have investigated various communication strategies, and one of them includes this notion of therapeutic lying. And so a lot of today's talk is going to be actually an animation. We have a series of animations which we've produced along with our communication course, and I'm going to show you the one on therapeutic lies. The first thing is that there are many concerns, and Kate mentioned some of them. There's a concern that it's unethical, and also it's against certain professional guidelines, certainly in terms of nursing midwifery. They would not support the use of lies. Kitwood, in his discussion about person-centered care, would call this work treachery. He may have done, maybe not now, if he was still alive, perhaps. Should we be deceiving vulnerable people? I'm not sure. People can tell you're lying, and Kate sort of alluded to this notion. Now, many family members say, we've been together for many years, or I've known my mum or dad for many years, and they can always tell when I'm lying. Underlines the notion of trust. And again, Kate was talking about this issue. And what if someone remembers later? What happens then? They'll know you've lied, and that will ruin the relationship. And obviously, if lots of people are telling different lies or different versions of the truth, it'll create a great deal more of confusion. But by the end of the presentation, I hope to have persuaded you that lies are person-centered. They're part of a whole group of strategies which need to be used well, but they are part of a toolbox. And to that extent, we should be training people to be better liars. And that's quite a controversial notion. And we've run some courses on this notion, and I have a paper on this presentation. Also, one of the key things is that lies are universal. They're being told in every care home around the world at this point. And what we've got to try and prevent is the use of inappropriate lying. And many NHS trusts and health boards, what we're saying is that they need to be written within their guidelines, the use of these things, because they're used on many wards too. Okay, we've written lots of stuff on this. Some of it's good, much of it is okay, some of it is poor. But since 2004, we've been writing regularly on this particular topic. And there are some books, again, which outline how we use and how they fit in with the broader issues of communication and person-centered care. Now, the thing about lies is that they are used all the time. They're part of the social fabric. You know, if you go to, for lunch with somebody or a dinner party or whatever you go to, sometimes you get quite dodgy food, but you wouldn't dream of saying that was really pretty mediocre, would you? Or, sometimes my wife will say to me, do I look good in this? And she may not all the time. She may say, does my bottom look big in this? And perhaps some of the times it might. But I would not say that to her, and she'd play the game with me as well. I would say to her, that's a new dress. She would say to me, you just never notice. I've had this for years. It's been in the cupboard. I've got it in a sale, whatever. And obviously our children as well. Our children are told lies quite frequently about Father Christmas, the Tooth Fairy. And my daughter's quite good at art, but in the beginning, she was bringing quite rubbish art home. But I would just say, it was so good, Keris, this is fantastic. This is the best I've ever seen. It's part of the social fabric. We lie from a very early age. Those of you who know about the marshmallow test, where we leave a child in a room with a marshmallow and ask them not to eat it. And if they don't eat it, they'll get 2 later on. What you'll find is that a lot of the children will take the middle out of the marshmallow and leave the shell of the marshmallow there to fool us. So we're lying very early on. And obviously some people who I guess maybe childlike at times, but no longer children, may be lying too at certain times. So my interest in the area was really to do with challenging behaviour. Now, how do we work with people who engage in behaviours that challenge stress and distress, whatever term we're using at the moment? And these are behaviours of humanity. These are not behaviours of dementia. Many of us will be performing many of these sorts of activities if we go out on the high street or to a pub of a weekend, perhaps. Now, the treatment of many of those conditions, if you look at guidelines, they'll talk about music therapy, dance therapy, aromatherapy, doll therapy, paro, activity therapy. So these are all good therapies, of course they are, but the evidence base for them is pretty poor. What I think we understand which makes them effective and not is the communication processes that go along beside them. So to deliver therapy well, we need to introduce it well. We need to encourage the person to engage in it well. So communication is vital in all parts of dementia care. My particular interest here, the management strategies for behaviours that challenge, my particular interest is in care practices. So because I'm not a great fan of this notion of person-centered, because most of the work, most of the mechanism of change when you're working with people with dementia is through the carers. It's the carers who have to change their practice oftentimes, certainly in later stages of dementia. So a lot of our focus is on the way staff speak and their intention. Now, we've been involved in a lot of work about producing guidelines about what good communication skills would look like. There are formulations, and I've been involved intimately with many types of formulations across the years. But what we understand is that the staff in our care homes, the staff on our wards are experts in behaviours that challenge. They're dealing with them minute by minute, hour by hour. They have a whole wealth of skills. And it's normally about some kind of the way they're communicating, but they often cannot articulate what they're doing. And one of the things I've been interested in is good communication skills. How do you get staff to articulate their skill sets? So we've been interested in McDonald's, Marks and Spencer's, and customer care skills, how those stores train their staff to be good at communicating. And we want to use those and transpose those into dementia care, because those skills are fundamental, make us feel good about ourselves. I was interested in what Brenda Phillips was talking about, the Montessori objectives. Objective 2 sounds very much like the sorts of things we teach in this core, this CAIT program, this core aspect of that. Obviously, you need some dementia-specific skills, and around certain personal care activities, you need to be taught, and we need to understand why staff are able to engage and undertake personal skills so well, because they're the spokes of the model, because they're the times when you often get behaviours that challenge occurring, but that intimate task. So the interest for me is this communication area. How do we get people to do things sometimes they don't want to do, and not to get distressed, and not to be engaged in behaviours that challenge? One of the other things we need to do is look at the nature of behaviours that challenge and understand that they're not a single entity. All behaviours that challenge have 5 phases. They have a well-being phase where the person is content. Then there's a triggering phase where something will trigger the response. Then there's an escalation phase where the person's emotions are increasing. Then there's a crisis phase, and that can be a very, very distressed phase for the person, or sometimes can be marked by hostility. Then there's a calming phase, and during that calming phase, we need to be careful in what we say and do, because the distress can be triggered again. So we need to understand our behavior around these phases. And this is where therapeutic lying is important, because it may help us to de-escalate, may help us preventing the triggering of the distress. So the typical sort of scenario where you would use a therapeutic lie is when you have a different perspective to somebody else. So because of the dementia, the person may no longer hold the same reality as you, may no longer be thinking in the same kind of way, and maybe time shifted. So you have got to decide whether you are going to try to bring them into your world, reorientate them to your world, perhaps through reality orientation, or go with them in their world. And their world may be, say, 20, 30 years ago when they were working, when they had young children. If you choose to go into their world, you often come into the notion of therapeutic lying, or CAIT calls some of this fiblets, which are lies. We may dress them up as calling them fiblets, which is a term often used in the States, but they're lies. So when do we use lies? We tend to use lies when people have very poor short-term memories and they lose insight to the fact they've got a dementia. Because they've got a very poor short-term memory, the continuity of their timeline, they've lost the continuity of their timeline. They don't know perhaps where they've just been, what they've just done, what's just happened. So to navigate their world, they need to go back in time. And sometimes they can go way back, and as I said, 20, 30 years ago. So they're not holding the same reality as the rest of us. If they no longer have insight that they may be engaging this process because of the dementia, if they no longer think they've got a dementia, but they're completely right, and they don't know why you're having a dispute with them, at that point, we may choose to go directly into their world and work with them in that. Now, we produced this video, this animation, as part of a suite of animations a number of months ago. So let's just think of it. This sort of summarizes the work I've just been talking about.
Hello and welcome to this video on therapeutic lying in dementia care. This video will explain the reasons why therapeutic lying is ethical and should be used as a form of person-centered communication in the care of people with dementia. In the past, people have reacted to the topic with alarm. Some of the common concerns and objections to lying have been: lying is unethical. It's against my personal beliefs. You shouldn't lie to a vulnerable person. You lose trust. It confuses the person, and it can be avoided. This video will address each of these concerns and explain how lying can be ethical practice. Let's start by talking about the general use of lying. Research shows that the average person lies 3 to 6 times every day. We justify these lies by renaming them as fibs, white lies, being economical with the truth, etc. Lying is something we do every day, and it's often for the benefit of other people. When we lie, we probably have a justification for doing it. First, let's clarify what's meant by a lie. A lie is any phrase or action that attempts to intentionally deceive. Blum outlined some types of lying which we have extended through research. Types of lying include outright lies, white lies, going along, not telling, tricking, or environmental manipulation. Outright lies are lies which are completely untrue and there is no likelihood it will come true. For example, please get up and dress because your family are visiting later, when the carer knows that this isn't true. A white lie is one that's perceived by the user to be a minor lie because they use qualifications or because it may be true at some point in the future. For example, go and sit down for a while. I think your favourite TV programme will be on soon. Going along is when you fail to correct a person's misperception of a situation. For example, I'm looking forward to seeing my wife later. Well, that'll be fun, when the carer knows that his wife has died. Not telling is missing out relevant information with the intention to manipulate their actions. For example, it's a nice day, let's go for a drive, when in reality the person is being taken to the dentist. Tricking is when a person creates confusion to make a person's behaviour more malleable. For example, speaking so quickly that they're not able to understand what's being communicated. Environmental manipulation is when the surroundings are altered in order to deceive. For example, painting the exit door the same colour as the wall to avoid exiting behaviours. Lies can form an important part of dementia care because of the cognitive difficulties experienced with the illness, which include memory problems causing time shifting and loss of insight. Time shifting occurs because people lose the ability to orientate themselves to their own timeline because their short-term memory has deteriorated. If they're not able to draw information from their situation from their short-term memory, they will make a guess based on their long-term memory. For example, Joe, an 80-year-old man living in care, wakes up from a nap and wonders why he's in an old people's home. Because his short-term memory is limited, he may conclude that he must be at work on a job. As he was a plumber, he sets about trying to fix a sink. This shows how Joe is time-shifted to a different period in his life, and also that he lacks insight into his illness. He's living in a different reality to the people around him. If we're going to communicate with him in this different reality, we have 3 options. We can try and bring him into our reality, we can enter into his reality, which often leads to lies, or we can enforce neither, the sitting on the fence approach. From our intensive research into this area, we've found that entering their reality can be the most compassionate approach. Orientating to our reality by using calendars, photos, or newspapers to remind residents when and where they are can help them to engage in topical conversations. However, this can be frightening if what you're trying to reorientate them to doesn't make sense in their reality. It also may simply be forgotten about in just a few moments' time. Sitting on the fence, although a common option chosen, is unsustainable. The person with dementia, not being stupid, will pick up on the evasiveness and be suspicious about the strange way that you're answering their questions. Going along with a person's incorrect ideas or beliefs can be the kindest approach. Discussing the topic by immersing fully into their world gives us a full range of skills to validate, praise, and empathise with what's being discussed. For example, I spoke to my wife this morning. Did you have a good chat? Yes, she told me our son passed his exams. You must be proud. I bet he's clever like you. Did you know I was the first in my village to go to college? Tell me about it. Our research showed us that 95% of care home staff admit to lying, and that those providing more hands-on care lie the most, probably because they communicate with the residents more frequently. While we were concerned about the negatives of lying, we realised that lies were being used anyway, but in an unregulated fashion. We didn't want this to continue and felt we needed to bring the issue out into the open. In collaboration with care home staff and families, we produced a set of guidelines. They were not developed to support the use of lies, but to clarify the terms by which they could be used. The guidelines are: lies should only be told if they are in the best interests of the resident. Specific areas, such as medication compliance and aggressive behaviour, require individualised policies that are documented in the care plan. A clear definition of what constitutes a lie should be agreed within each setting. Mental capacity assessments should be done prior to the use of therapeutic lies. If an individual has mental capacity, then lies are unlikely to be used, although they may be able to make decisions about the use of lies in the future, for example if they become delirious. Communication with families is required and their consent should be gained. Once a lie has been agreed, it must be used consistently across people and settings to prevent the confusion of different people telling different lies. All lies told should be documented, and the rationale for each lie should be explained and justified. An individualised, flexible approach should be adopted towards each case, and the cost versus benefit of each lie should be established. Staff should feel supported by families and management, and should not feel at risk for telling appropriate lies. Circumstances in which a lie should not be told should be outlined and documented for both the setting and each individual resident. The act of telling lies should not lead staff to disrespect the residents. They should be seen as a strategy to enhance their well-being rather than an infringement of their basic rights. Staff should receive training and supervision on the potential problems of lying and taught alternative strategies to use when lies are not appropriate. Clearly, this is a complex issue, and training is required to help staff recognise when and which lies are appropriate. In Newcastle, we've developed a training programme called Communication and Interaction Training, or CAIT. This training develops a range of dementia-focused communication skills, including therapeutic lies. In CAIT, lying is considered the last resort in a 4-step hierarchy. So if someone is making a difficult request, like asking to see their husband who has died, step 1 is to try and meet the need. Obviously, getting their husband is not possible, but the underlying need might be companionship, positive touch, or just someone to chat to. If this is unsuccessful, you move to step 2, substitute the need. For example, getting another family member to speak to the person, perhaps over the phone. If this doesn't help, step 3 is to distract. This is difficult when someone is highly emotional, so a lot of skill is required to capture a person's attention long enough to forget the need. This is when it's helpful when the carer knows the person really well, because the carer can enthusiastically try and engage the person in a topic of conversation that will shift their attention away from the need. If all of the above fails, this is the only time lying is justified. In this instance, you construct a lie that complies with the guidelines, is person-centred, and based on events from their life, so it's believable. A lie which does not fulfil these criteria could have terrible consequences. An example from our own ward was a lady who was told her husband had gone fishing, but he had never been fishing in his life. The only explanation she could think of for being lied to was that her husband was having an affair. It's sometimes argued that telling the truth in this situation would have been better, but if she gets upset every time she's told her husband has died, this could be highly traumatic. There are also instances where telling the truth can undermine trust. An example of this was a gentleman who was informed his wife had died, and he became really angry, telling the carer he'd been married for 55 years and that he would know if his wife had died. A final issue is that we're often asked why we insist on calling it a lie, as it's such a problematic word. Our response goes back to why we started all this research. We want to bring the issue out into the open, and the term grabs people's attention. I hope you can see how there are instances where therapeutic lying in dementia care can be not only ethical, but in fact the most appropriate communication.
So that's the animation. It's available on Ian James YouTube. So if you put Ian James Dementia on YouTube, there's a series of about 8 animations in that series. As I said, we have conducted a number of studies, particularly psychologists saying, you know, do you think it's important to be able to, to train people to lie properly and well without making some of the mistakes that have been demonstrated in that clip? And after the training that we gave the staff, they endorsed the idea that we should be training people to be better liars. There is a document by Mental Health Foundation which partly supports the use of lying in the UK. we've got to remember that it's not just vocal lies. Doll therapy is a form of deception. The parasealers, painting doors. So environmental lies are quite common. I'm not going to talk about the bangs technique, but many techniques people use, including Teeper Snow, they would say they were not lies, but actually they're deceptive practices. And we've got to be very aware of that. And the final thing is, we have a PhD student looking at lies in situ, working on wards at the moment, and seeing how many lies are being told and what type of lies are being told. And finally, we're using a similar methodology about looking at lies, both in psychosis, learning disability, and working with children, because each of these areas, the patients, the clients, are holding a different perception of the world. And in that case, the use of lies is quite prevalent in such settings by the caregivers. And we have now at least 2 studies looking at lies being used with people with learning disabilities. Okay, thank you very much.
Thank you so much for that, Ian, and very thought-provoking and quite different approach to CAITs. I'll maybe start the discussion by just asking Kate if you have, and likewise maybe Ian, if you have any thoughts, having each kind of heard here the different kinds of approaches. I thought it was interesting that your program is called CAIT. So what does Kate think about Kate?
I was kind of obsessed with the person who was doing the voiceover of Kate sounds like me. But then I may be deluding myself, so I don't sound like that anymore. I mean, obviously, and absolutely fundamentally respect everything that Ian said, and there is absolutely more in common between our positions than there is in difference. And I suppose I suppose I would see the danger as saying that therapeutic. I think, you know, the fact that people do lie all the time anyway, in life and in dementia, it does make it a dangerous thing, because it's easier to do that than to tell the truth very often. You know, it is very hard sometimes to tell the truth, and so very often I do, you know, I check myself constantly with people with dementia, that like, have I been through the cycle of knowing whether it's appropriate to lie now, because now they may be lucid and now they may be able to take in more than they could this morning or last night or whatever. So I think that's the emphasis and it feels like a let off to me to call it therapeutic. It's lying, and I completely agree. And I think that is a really very powerful message to bring lying out of the closet, because we're using lies constantly when we're caring for people with dementia, and using them with the right intent very often, but oftentimes they're used and there's no good intent, because it is an easier thing to do than to tell the truth. For example, I was teaching home care workers about person-centered dementia care, and one of them said to me, "Oh, I just tell the person that I'm a nun and she lets me do anything." And I think there's a big danger in people getting the wrong end of the stick, that therapeutic lying is a good thing, and so therefore we should just lie. So my reticence with anything that Ian says is only in this kind of semantic difference between, and I should say as well, mine was all kind of personally involved, and Ian's is very much research based. And it's interesting, we both came up with the 4 steps. Like, I think, well, I don't know whether your 4 steps are exactly the same as my 4 steps, but they're very similar. So I think there's more in common between what we've said than is different, and it is in the end maybe a semantic difference.
Yeah. So I think, yeah, the similarity is that's the interesting thing. I guess there's the notion that one of the things that you said, Kate, was, "What does she need from me at this moment?" was the quote you said, and I think that's really interesting, and that's why I think there is a place in the toolkit for a for a lie, because, you know, at that moment, the need might be a lie. And, you know, we've done a lot of work on this treading water. So some people, we had a criticism, and the person said, what I do instead is I do this, the verbal dance, which is what you've called treading water. But the thing I always find is when we try to do something like that, the person with dementia is really intelligent. What's happening, their intelligence hasn't changed. Certainly their social and their emotional intelligence hasn't changed. You know, and so they can tell that you're trying to talk around the houses, you're not being direct, you're not answering them properly. And you get yourself into all sorts of a mess when you're being, you know, evasive. So sometimes with some people, and certainly if you find in a particular setting, every time this topic comes up and you try to be evasive, the person gets really upset or really angry, then it's that point we need to come back and say, okay, what does this person need at this moment? And it may be a lie. The reason why we're quite keen on, you know, everyone, I mean, lots of people really dislike the notion of a lie. They really don't like, they want me to change it. And we have tried to change it for various different terms. But I think one of the terms was dementia-oriented realities. But you know, that didn't go too well and too far, really. But we have a paper about that term. Yeah, I think that a lie is a lie. We need to, if we're using them, we need to document them. They are a therapeutic tool. This is a guess. You know, if we give medication, we have to write a care plan for it. If we if we're saying lies and using them regularly, we need to care plan it, so when it can be used. And that's why the guidelines are important. We're seeing it as a therapeutic tool. It's not just, you know, an off-the-cuff thing, because that's highly problematic as well. And that's what we're trying to teach people not to do. But when you are telling one, we need to look at the impact of it.
Yeah. And Clodagh is saying in the chat box there, do we think that healthcare workers might tell a lie to kind of quieten somebody down instead of addressing an unmet need? But I think that was quite clearly kind of dealt with in Ian's model, in that I think that was step one, wasn't it, that you assess the situation. But that's my problem with the calling it a lie or calling it therapeutic. No, calling it a lie I have no problem with, and doing that occasionally I have no problem with. I think, but I think it's very clear that in Ian's model, this is not something we can do loosely, because it has to be properly planned, and that you could never tell a lie before you've tried to work around what might be driving a particular behavior, and it may not be the thing that they're talking about. So telling a lie could be completely irrelevant, and it wouldn't even help you, and it certainly wouldn't be therapeutic if it's in fact the case that somebody's saying something that is actually a marker for the fact they need to go to the toilet, or they've been incontinent, or some other kind of deep-seated need that they have for company, or whatever it may be. So I think yes, Clodagh, that is completely a risk of lying, and I think that's the one reason I find it's difficult to call it therapeutic, because I see people's kind of leaning towards doing this less carefully than Ian is advocating.
Yeah, I mean, I agree. I'm intentionally being provocative. I understand that, and this, you know, that silly thing I'm saying about we should teach people to be better liars. I know that is really, that does, but the point there is, I guess it's getting the debate around that, because there is a truth in that. You know, if we're choosing to tell, to use lies as a tool, we do need to be using it properly. So what I'm saying is, it doesn't mean to sound flippant, but it is to get people speaking and debating the issue. So yeah, sorry, I know I upset lots of people when I talk about these things.
I wonder about, the only question I had about the model was the idea, and of course, I'm talking about caring for mum, and you're talking about care in organised institutions, but the idea that you have to assess capacity but assessing capacity is different from it's not a black and white. Well, in the law in Ireland and certainly in the UK, it's not quite you've not quite gone as far as we've gone in terms of we've got rid of the whole language of best interest has gone from our law, and we have entirely will and preference. We've gone the whole way over to will and preference, but capacity cannot be really assessed as a black and white thing. So you would need to, I suppose one of the fundamental things about what I'm arguing is you need to, in that dance, you're assessing capacity. And so rather than having a universal thing, we all tell a lie. Whenever she says, is it Thursday? You always say, yes, it is, because Thursday is pension day and that's a good day for, and these are approaches that I've heard in care homes in the past where, Thursday was a good day. If you tell her it's Thursday, she'll be happy, whereas my explorations with the same lady was very much along the lines of, well, sometimes she's perfectly happy that it's Monday or Tuesday, and there are some days when she really needs it to be Thursday, and that's for reasons we can explore if we enter into that world of what Thursday means to her. But to be consistently always saying yes, it's Thursday today feels like the ultimate in disrespect to me. So that black and white capacity is a bit of a problem when you're doing care in more of an organised way than I'm talking about with just mum.
Yeah, I completely agree. And the idea of mental capacity, we had, in some senses, it wasn't in the original guidelines. In the original guidelines, it was degree of insight. It was more from a theoretical perspective, because we put mental capacity in really when we were trying to get it published in psychiatry journals, because they wanted that aspect in, that more legalistic aspect. But I guess part of the teaching is if someone's moving in and out of their present reality, lies are really problematic. So insight becomes really important, levels of insight. So when on our training course, we talk about insight, not capacity. And what do you mean by insight? There's lots of different types of insight. And that's why it's a really complicated area. And that's why we think, so in the early days, we had people walking out of talks. I've had a few people walk out of talks, but most people stay in now. Don't always agree, but the issue is that it's worthy of debate because it is so complex. And so yeah.
There's a really good question there. Sorry, Sinead.
Yeah, I was just going to say, and that has come up here, and also when truth telling was on the program, just a few people saying, look, thank you, yes, it's, let's get this out into the open, as you said earlier on, Ian. A question has come up here from Tanya about the multicultural kind of perspective on this, and Tanya's asking, are we running the risk of imposing an Anglo-American perspective on the world when there are alternate visions that we should also consider?
I think yes, and I think I kind of acknowledged my cultural upbringing in terms of the difficulty with the lie. I'm kind of, well, not in religion, but in background at least, a white Anglo-Saxon Protestant who kind of really, really struggles with the idea of lying because it was a very strong part of my moral upbringing that telling lies was a wrong thing to do. And so it is really difficult for me in a way that, people from different cultures play around with social imagery and the social imagination to a much greater extent. And I have to confess, Tanya, to being quite ignorant of those cultural backgrounds, other than having an awareness there are different cultures where to tell a lie has a very different interpretation than it would have to me.
And in your training, you probably was there a multicultural? The people who are working in care centres now really is very multicultural. So in your training, Ian, did you get any feedback on that, or did you adapt the program as a result?
Well, we've got a large South Asian community in Newcastle, and I've got to say, and that may be due to all sorts of reasons. I'm not saying everyone from South Asia agrees with lies, but they have have less of a difficulty with this notion. But I guess the issue, the big confounding problem we have about saying it's a cultural issue is that we have a hierarchy. The people who spend more physical time with people with dementia, the staff who spend more physical time, lie more frequently and are happier about using lies. So we did a study in an acute hospital, and the medics didn't use lies hardly at all. We were very interested in this, whereas the nursing assistants were lying a lot. And we asked the medics why they weren't lying. They said, well, we just don't spend enough time with the patients. So they didn't need to. And also, we were thinking, well, you're telling them and the family really difficult things about what might happen next. And they said, if you have anything really difficult to say, we ask the nurses and the nursing assistants to talk to the patients or the staff like that. And I think that's amazing. You know, certainly in the UK, the most people we give the least training to some extent and the least education are talking about very, very difficult things. And some of our medics are not engaged in this sort of conversations. So there is a confound there about, you know, more time you're spending in delivering care, hands-on care, the more you're using it anyway. And so the approval ratings are higher.
I suppose, though, in fairness to the medics, the people who spend most time with the people with dementia do know the person well enough to tell a lie that's going to be of some comfort to the person with dementia, because if you don't know a person, it is actually, I would contend, impossible to tell a lie that would ever be in anywhere reaching being therapeutic. So for the doctors to work collegially, and I think certainly in terms of gerontologists I've worked with, they're the best team players ever, and they will invite nurses in for difficult conversations. But I don't know, my experience always would be there as well. Not just leave us abandoned to it.
But my thought would be they should be aware of this issue. This is an important issue they should be aware of, and they should be supporting staff through these very, very difficult conversations. But in the particular piece of research, they were a little bit dismissive, I've got to say, about this issue because it wasn't one of their issues. And that was a project done at Lancaster University.
Yeah, perhaps not all, though. I would think to some degree, I suppose, alongside CAIT there would be geriatricians and doctors working in this area who are very much on the same page. We actually have, and I might finish up with this question if that's okay, or it's more a comment from Greg Swanwick, saying that is there a danger in focusing too much on the immediate need without equal consideration to the medium-term impacts, that might be also a key to training carers to kind of do it properly. Do you have any comment on that?
Yeah, so we were in the acute study, we weren't talking about geriatricians or psychiatrists. So this is one of the big problems. You know, by solving something immediately, you may be laying store problems later on. And that's what part of the training is about. So to get a quick win, to get someone to do something that they perhaps didn't want to do, if that stores up negative emotions next time, you have a big problem. So we wouldn't be supportive of that. And that's the importance of the care planning. So what we need to do as part of the care plan, you evaluate the impact of what you've done. So someone didn't want to get up or want to take medication, or there was some personal care activity. If through lying you got them to do it, if you did it in the wrong kind of way, next time it may be even harder to assist with that activity. So it is really important that we evaluate it properly. And that's why the care planning and feedback is so crucial.
Yeah, I suppose it's a series of options, as you said. And I do think both Ian and Kate, there were a lot of similarities in your approach, although differences as well. So thank you so much. Before we end here, I'm just going to launch a little poll just so that people can give us an idea, just to get a little bit of response there from it. And Thank you. Yeah, thank you so much for taking the time and, you know, sharing with, you know, kind of the debate of an issue that is so little spoken of, but is such a huge issue. Just a comment for our next plenary session is starting at 3 p.m. and it's emerging concepts in diagnosing and treating Alzheimer's disease. And there are lots of thank yous coming in here on the panel for yourself and Ian. Take care. Thank you.
Thank you, everyone. Thanks, Ian.
Thanks. Thank you. Well done.
Yeah, we didn't come to blows.
Good to meet you.
What did you say?
I said good to meet you. If you want to if you're interested in doing any research, we'd be very happy to help.
Yeah, well, we could think of something for Wellcome Trust, couldn't we? I'm trying to think of outside of Europe things. Wellcome Trust could be a good one to work on. I'm really interested in decision making more generally, which could be a really
I know I'm here. I might put the two of you in touch with each other directly if that's okay. Before we log off, Ian, would you mind shouting out there again where people can see those videos? You said it was on YouTube.
Yeah, so it's just freely available. So it's Ian James Dementia. If you put Ian James Dementia on YouTube, there's about 8 animations that'll pop up.
Okay, great. And we will try and get that and put it up on our website actually, because people may very well be interested.
So am I delusional or do I sound like your PhD student?
No, I don't think you do. I don't think
no,
you do.
I listened and I was like, God, that sounds like me talking. I think it might sound like me about 20 years ago.
Yeah, no, I think your accent has changed, I think. So Sinead, was that okay? Was that...
Yes, thank you so much. I'm reluctant to click end here, so I'm waiting for the conversation to just naturally end, and then when I click end it will be quite abrupt, but I would encourage you to continue the conversation, and thank you so much.
Brilliant.
Good
Thanks.
stuff. All right, lovely
Bye.
to meet you. Thanks, Sinead. Bye-bye. See you in a little while.